The door's actually pretty interesting because you have lead and plastic. You can't just have lead. Ignoring specialty procedures, just everyday run-of-the-mill procedures, you can do up to, say, 30 to 35 per day, 5 days a week. There's certain specialty procedures which take longer and would cut into that a little bit, but in general about 30, 35.
And what is the difference then between the regular procedures you do versus what are specialty procedures?
A specialty procedure would be stereotactic radiation, which the normal daily dose of radiation is about 180 to 200 centigrade per day. With a stereotactic treatment, you're treating at least 1,200 centigrade per day, up to about 2,000, sometimes even higher doses. When you do a higher dose, it takes more time to deliver the radiation. It also takes a lot more time to set up and verify that you're doing it safely.
And you'll find quite a bit. BrainLab has some, but I think Varian has more than I've seen anywhere else.
In order to become a radiation oncologist, it takes about 4 years of residency plus a internal medicine year. And so I obviously did that, completed that, and have been working after residency for about 3 years. There's some key therapies that you do not use for radiation treatment. There's some that it also depends on the disease state. Breast cancer, for instance, you treat sufficiently. Cancer, you treat chemotherapy. So there's different options in if you want to pin set something on the top of that.
This is a really tough question to answer, but of all the patients that get referred to you, what percentage would you say are actually treatable with radiation?
You mean curable or treatable?
Treatable.
90%.
The vast majority.
Vast majority.
So most of the
Everybody
people
needs
that get referred
X-rays.
to you, everybody needs X-ray. That's right. Most of the people who get referred to you, it's already kind of been decided that they probably are going to need some form of radiation.
Generally so. And that's not... I'd say the challenge is always with certain diseases that have low cure rates. How do you improve upon that? And how do you interact with newer and better chemotherapy agents? So I think just improving the cure rate is always, even if you have a 90% cure rate, you still don't want 1 out of 10 patients having a problem. It's the most important of everything.
Of course it is.
I mean, basically, it's very disease dependent. You have medical oncology, you have surgery, internal medicine. I would say that everything begins with the primary care provider, and then they will send the patient on to the specialist as needed, generally onto the surgeon or the medical oncologist, and then myself. And it's hard to really narrow that down in a minute or two, but basically when it comes to treatment, we're a local treatment, so we are usually complementary to the surgeon, whereas chemotherapy, it's really, really nice having the contrast injector. That is extremely useful.
I bet.
So,
Very good. Well, I thank you very much for this time in the interview.
you're welcome.
Appreciate it.
I hope I'm not on YouTube now.
Don't